In the next 5 years, all plastic surgery practices around the world will be redefined, recalibrated based on the use of this medication. When there's a gain, there's always a loss.
Yeah.
That's the laws of universe. And unfortunately, our colleagues, the bariatric colleagues, they have anecdotally dropped 70%. That's a huge number. That has pretty much almost wiped out a whole specialty of plastic surgery. The trend is towards very natural looking. People are wanting to undergo surgery just to get the padded bra look now. It's called the ballerina boob job.
Welcome to Inside Aesthetics, the world's leading podcast for cosmetic practitioners and business owners.
Our podcasts are aimed at medical professionals and should not be used to make medical, legal, or financial decisions. You should get an appropriately tailored piece of advice from a professional in your country.
To show your support and stay up to date with our latest episodes, click the follow button if you're listening on Apple Podcasts or Spotify. And if you're watching our episodes on YouTube, hit the subscribe button as well as the bell icon.
If you're interested in joining our online community, being a guest on the podcast, or would like to work with us, all of our contact details are in the show notes. And now, let's jump into today's episode.
It's our last podcast recording of 2025, David.
Already?
Yeah. Did you have a happy Christmas? What did you get up to?
Local, family, chill, a couple of dinners with friends, actually. Yes, it's been good.
Yeah, we had,
One of your guests from Christmas is in the studio today.
Well, it's exciting because it's only our second guest since we've sort of reimagined the studio, which for anyone that doesn't know is a spare bedroom in my house.
Yeah. So we welcome back Dr Kourosh Tavakoli, who we had on episode 69 in June 2020. So it's been a minute.
It has been a little minute.
It has. It's been about 5.5 years. Good to see you guys.
Yeah.
Thank you. A lot's happened since then. What's been happening in your world?
Oh, whoa.
Are you still the king of boobs?
Well, I've been dethroned, allegedly.
Yeah.
There's been a coup d'etat, and the powers to be have taken the crown away.
Right, okay.
But the soul remains the king.
Yeah.
It's just the title's gone.
Yeah.
Well, for our listeners who one, don't know you, and maybe two, missed, our episode 5.5 years ago, reintroduce yourself. What's your background? Who are you? And what do you do?
My name is Kourosh Tavakoli. I'm a local plastic surgeon, Australian plastic surgeon based in Sydney. I've been in practice 21 years now. Actually, probably today is the end of the 21 years.
Wow.
I'll be 22 next year.
Wow, congrats.
And thank you. So
commiserations.
My practice is mainly breast aesthetics, different types of breast surgery, and some body contouring to go with that. So that's the core of my practice.
Yeah.
Great.
And I'm based in Double Bay in Sydney, not far from your studios.
Yeah.
And I've been there, the current location, about 13.5 years.
Yeah.
So that's my story, and we can talk about the past 5 years since I've seen you guys.
Yeah.
Well, it's been a while since we've covered a surgical topic, to be honest. And Kourosh was one of our surgeons we had on years ago. We did faces, mummy makeovers, breast, and a little bit on massive weight loss surgery with Dr. Jeremy Hunt. But it's nice to revisit these trends, see what's going on, and it does tie more and more into what we're doing in the non-surgical space and also the regenerative space, weight loss space.
Yep.
So we're going to talk about all of that.
Yeah. Well, I guess the impetus for the conversation was a dinner that you and I were having with a few other friends a few nights ago, and we started talking about the industry and what's been happening, and the subject of GLP-1s came up. And it's something that hadn't occurred to me, and I'm assuming not Jake either, was not just the impact that GLP-1s are having on the non-surgical space in terms of, people wanting more volume in their face, but what it's doing in terms of demand and trends within the surgery space. And I hadn't even thought about people who now are wanting facelifts because of the weight loss, the decrease in the demand for things like liposuction. And so you were saying it's really kind of reshaped your practice, the demands, what people are wanting. So we're going to talk about that. We're going to talk a little bit about breast implants and the trends in general, like new modern techniques that are I guess sort of on the forefront. So the impact that's having on surgery. So now people needing lifts. So we're going to talk about that. We're going to talk about breast implant trends in general. We had that whole sort of blow up a few years ago with breast implant illness and do breast implants cause cancer and so on. And then I guess in terms of, new techniques and the use of mesh and things like that.
So I guess probably the easiest one to start with is breast trends. That's your sort of main thing. You've been doing that for your whole career.
Yeah.
10 years ago, I think, or even when you were on the podcast last time, you said that I think during around the GFC, there was a massive trend for bigger 450, 480cc implants. And then, I don't know, a few years ago, that got much smaller. So where are we now with the breast trends?
Look, overall, I'm very fortunate. I've got such a huge cross-sectional patients from different demographic and different walks of life. So I do see everything in terms of the tiny ones, moderate ones, and big ones. But the trend is basically in the past 5-10 years towards very natural looking. And it's kind of very strange. Sometimes a girl comes and asks for a B cup. Like, it's crazy. This particular year, I've heard people in the consult say B cup. I was like, no, I don't want your cup size now. What is the desired cup size? She goes, I just want to go and look like I've got a padded bra. And people are wanting to undergo surgery just to get the padded bra look now. It's called the ballerina boob job, which the patients have taught me. So the ballerina look is now in trend. I think, just touching on the topic of breast aesthetics and breast cosmetic surgery, a lot of awareness around breast implant illness. And I guess we won't go into too much details about breast implant illness because it's such a huge topic, and the immunology and the science and the physiology of it is beyond the scope of our podcast. But that raised a lot of awareness, especially during COVID with the COVID jab. And I got a COVID jab on my left arm, my boob has grown, I've got breast implant illness, that sort of narrative. And made people think twice about getting it done. But a breast implant illness is a huge entity or not, did raise awareness that if you stick something foreign in your body, do expect some changes. And there's, I guess that's one sort of the equation where implant usage worldwide has dropped because of that. So that's one important point. And not just the size, the actual use of it. So people would come and say, look, fix my breast, doc, just in summary. But I'm just telling you now, I'm not interested in implants. So the language of consultation has changed a lot. And then sort of that being on this side of the equation, then we've got this wonderful drug that just came out of nowhere. I'm not talking about the vaccine, by the way. We'll stay out of that one. Just out of nowhere, the revolution of GLP agonists, which is an amazing phenomenon, which parallels what's been happening since COVID, which is people wanting to be healthier, live longer, drink less alcohol, exercise more, and live to be 100. That's the new trend, the new flex. Who's going to live to 100?
Can I say, everything that you've just said is an exact mirror of what we're seeing in the injectable world. We're seeing this trend from overfilled face to natural, patients pushing back at some of the products that we traditionally use because they don't want it for whatever reason because of social media and what they've read. And also the rare complications like nodules or granulomas. We don't really understand the science, but we know it happens and it's rare. And patients, again, quite scared. And you get the odd patient who says, I'm sorry, but that product, it's just off the table for me. I only want a natural solution. And then GLP-1s have changed our practice. So it's exactly the same.
It is. The biggest difference between the surgical space, breast-wise and face, is that we've never had a suitable injectable alternative in breast surgery. You guys have Botox and wrinkle medications and a whole variety of fillers, boosters and so on, and then add lasers and radiofrequency, and you really can do a lot to someone's face in your space quite easily without the use of the surgical knife. Whereas in the breast space and bodies, I guess we had the CoolSculpt and a few other stuff in terms of tightening devices. But breast has always been you either operate on a breast or you don't operate on a breast. And that's been the biggest difference. I guess sort of going on the topic of weight loss and longevity and using the injectables or non-injectables or whatever it is a trend. If you want to do it naturally or unnaturally or using medical technology, is that the breast will shrink. And the people who was walking around with the C cup and being super happy and B cup, suddenly they've now gone from entered the red zone of, well, I'm now an A cup. I can't wear a dress. I can't put a bikini on. I don't want to have an implant. I'm being forced to. So it's opened up a whole demographic of patients who didn't want to have augmentation surgery. And quite ironically, they're getting fitter, healthier, but now they're coming back towards the implant world, and sort of the noise of the breast implant illness has reduced as well. So they're not sort of talking as much about it because like they just want the implant. And so and we can talk about the breast implant illness and whether the size of the implant matters and all that kind of stuff, which I personally believe it does. So yeah, so that's one thing. And the other area which Dave and I spoke over dinner was breast lift, which I used to do 10-20% of my practice was breast lifting. And now with the weight loss phenomena, it used to be bariatric surgery, but now with the GLP agonists, everyone is losing volume, but they're not losing the skin. So we're doing a lot more breast lifting of different types, whether with breast lifting with fat. And I guess since the last time I've been here, fat grafting has taken off even more because we've found ways of refining the fat and purifying it and injecting it in a much more predictable way. So fat grafting with breast lifting, or fat grafting as a standalone, or breast lifting as standalone, has just enormously increased in numbers. I would say it's the number one growth area in breast surgery.
So do you think that it is the GLP-1s that are predominantly driving the increase in lifts?
I would say it's a GLP-1 and the effect of GLP-1, because if a girl's taking the GLP-1 but her girlfriend is reticent and says, I'm not taking it, but she's still going to the gym and watching what she's eating. So it's a weight loss phenomena is pushing the breast lift and the speed of it. And this is something that, because if we are shrinking at a linear rate, a collagen elastin, as you both know, would shrink and adapt at a much better pace. Whereas GLP agonists, you can just increase the dose and you can drop 5 or 10 kilos very rapidly, and your skin won't have time to retract, and the elastin ratio just collapses. And then you end up with a lot of skin.
So to put that maybe in just some numbers, if you were to see 20 patients presenting for a consultation, what percentage of those people now are wanting lifts as opposed to maybe 2 or 3 years ago?
So we've done studies of, one of my publications was on this topic, and we did find that the topic of breast lift 10 years ago was a patient walking in and saying, I want an implant, and then I'll proceed with an examination and the breast would be quite droopy, and say, well, it's different. And they say, well, why is it different, Dr. Tavakoli? You've done all my friends and you put implants in them. It's like, well, it's a different operation for a different need, and so on and so forth. Now patients are a lot more savvy, much more educated. So when they come, they say, listen, I've done a lot of Google, looked at chat, I've done this and that. I don't believe I'm necessarily a candidate for an implant. I need a lift. I've accepted the scars. So all the hard work is done because of research and better education, but also want an implant. And sometimes, as you know, we don't put the implant straight away. We delay the process and say, look, we'll lift you first and use your native tissue to reconstruct you, probably some fat grafting from your legs or your back. And that sort of sits really well with patients. And that's just been the biggest change. Number-wise, I'd say probably at least 100% increase in breast lift.
Wow.
At least 100% increase.
From a facial aesthetic perspective, we often see patients, they start their GLP-1 and probably 2 or 3 months later, they're noticing it in the face. And sometimes we're trying to counsel them prior to them losing that weight that we might need to get ahead of the curve and do something to the face preemptively. So when are the patients noticing their breast tissue is changing? Like how far into their GLP-1 journey?
That's a good question, Joe. I think it varies from patient to patient, depends on the ratio of breast tissue to fat, because there's an equation. I normally say, let's just say the average person is 50-50. There are some girls who are 90% breast tissue and very little fat, so they don't get affected by weight loss. And then there are ladies who just 90% of the breast is fat and they just completely collapse.
Can you tell that on examination, or is it just...
You can. But by the time patients come, they've already self-selected. We're not general practitioners. They're not walking and talking about these topics. They've already done all that discussion. Yeah. They've done the research. They've done everything. So by the time a patient walks into my practice, has gone probably through the whole process of knowing what she needs. I'd say she, because I don't I don't operate on men. And they've gone through the selection process of finding the surgeon, the credentials. So they sit in front of you, very
Highly
well educated,
filtered,
and they say, okay, this is what's happened to me. And then the discussion usually is, I put a bikini, I look empty, my upper pole is gone. I wear a dress, I have to strap the dress with tape when I go out, and so on and so forth.
We weren't going to talk about this, but you raised the term ChatGPT.
Yes.
What influence has that had on patient education? Is it better? Is it worse? Is it making your life more difficult?
I would say a bit of both. I think it's huge. I think the demographic of 18, I'll say 18 because we don't operate under 18, but my kids' age, teenagers, even more. The 18 to 28, almost, I would say 80% of their usage is chat. So chat is like, hi, how you going? And then they jump onto Google and Instagram simultaneously. And then the last port, I've done this and I've spoken to patients, and the last port of verification is just different ways of verifying who you are. Tick, tick, tick. One tick is your chat, which is a good tick. And then your second chat is your Instagram. And then Google, obviously. Then they'll go finally to your website and check you out properly. And that's just, if you add word of mouth to that equation, and then you've got the whole gamut of the social media credential, chat credential, which is, I would say, is different, and obviously just your reputation.
But were you implying, David, that, we used to kind of joke about Professor Google and patients coming in knowing everything? Well, with AI, ChatGPT, etc., there's like a new layer to that sort of patient knowing everything, which is, I think it's kind of good. You're empowering people to know, make the consult maybe a little bit more efficient. But do you find that patients, especially with surgery, they're coming in with a predefined goal that doesn't always work?
Yeah. I mean, there's still, I'd say number-wise, 30% of the consult is still labored. Patients are a little bit difficult in terms of their expectations, and they make comments which are unrealistic, and so there's a lot of education that can go, and you can have a good day and you can have a good bunch of patients who are so well informed that the consultation runs very smoothly. The selection process of implant or procedure is very nicely done, and there are the days where the Professor Google stepped in and the patient just wants to challenge you on things which can't happen. And a lot of it is because, let's say, the easiest example is she doesn't want a scar, and she'll push you towards using an implant where it's like, I don't want to have scars. I know 3 of my friends who've had successful operations, and they've had implants put in, and why would you want to lift me and do this and do that? So that's the natural part of any cosmetic consultation. You guys would have that in the injectable space as well.
You put up some stats, David, that still a lot, but only 2% currently of Australians are apparently on a GLP-1. It's still a massive explosion in the last 2 years, but compared to America, these stats say 6 to 7% of the US population. So even if you've noticed a massive change and it's only 2% of Australians, when it's, 5 or 10%, it's going to totally change your practice.
Yeah, I think in the next 5 years, all plastic surgery practices around the world will be redefined, recalibrated based on the use of this medication. Especially, as you guys know, the oral tablet version just got approved, FDA approved in the States, Ozempic tablet. And that's just going to open a whole paradigm of patients who probably for many reasons did not want to use an injectable means of losing weight, taking a tablet daily. That's just going to open up another section of patients which went privy to the world of plastic surgery. Look, I think still there are a lot of patients who are using GLP agonists and not seeking plastic surgery. So the main benefit of this medication is health, lowering your cholesterol, stabilizing your sugar, reducing your cardiovascular risk, and so on. So let's not lose the big picture that these medications are prolonging life and longevity. And I think it's quite interesting that as people live longer, and that's where the long-term plastic surgery kicks in. So I always look at this as a short-term gain, which is what we discussed the other day. Short-term has been a big increase in demand this year. I'd say it's, at my practice, probably about 10-20%, which is quite reasonable. But I think long-term patients are going to live longer. That's very simple. A 60-year-old getting a breast augmentation is not going to be a weird thing anymore. A 75-year-old getting a facelift is not going to be weird, because a 75-year-old doesn't necessarily look old anymore, or in fact, they feel great about themselves. They feel healthy. Heart's working perfectly. Everything's looking good. The risk of dementia has been known to be reduced by reducing obesity. So people living longer, they're going to be needing more plastic surgery, and plastic surgery will go well into the 7th decade and maybe even to the 8th decade, where 80-year-olds are getting facelifts.
Something else that we spoke about, and I know it's not your area of expertise, and I hadn't thought about this, was just the reducing the demand for bariatric surgery. So people that were undergoing sleeves and gastric bypasses and so on, that's demolished that entire surgical demand overnight.
Yes, when there's a gain, there's always a loss.
Yeah.
That's the laws of universe, and everything evens out. And unfortunately, our colleagues, the bariatric colleagues, and I'm not an expert, but I do work with them closely for the past 10 years, because especially body contouring and getting them ready for surgery, bariatric surgeons were a big part of my practice. And they have anecdotally dropped 70%.
Wow.
70%. So that's a huge number. That has pretty much almost wiped out a whole specialty of plastic surgery. A bit like the effect of cardiac stenting in the 90s, which wiped out 70% of cardiac surgery.
Same as PPIs, when they were invented.
That's right.
Suddenly a lot of surgery for gastric acid just disappeared overnight.
Correct.
Just take a pill and
yeah,
you're
that
fine.
was in the 70s. So every now and then something happened in surgery, and it would be like the internet moment where some people benefit immensely out of it and some people don't. But the big benefit, it goes to the patient.
Of course.
And the patients are living longer, healthier, more active lifestyle. So this drug overall, despite its side effects, let's not lose sight of the fact that some patients can't tolerate them. Nausea, vomiting, gastric bloating, generally have to stop taking them. And that's going to be an evolution. There'll be more refined versions of the GLP agonists that's going to emerge, where the side effects are less and less. But so as you said, Dave, the bariatric surgeons have been affected. And the other interesting area, which I think I touched on, and it's been crazy affected. I don't have numbers because the liposuction, the 2 largest liposuction clinics in Australia got wiped out a few years ago by all the issues with the mainstream media. I would say they would have been wiped off anyway because of the GLP agonists, and that's liposuction. Liposuction per se, without additional body contouring, is greatly diminished, as there's no need for it. If you have a choice of having a metal rod inserted in your body over 3 hours of anesthetic at the cost of 10, 20, 30,000, or taking an injection, I think it's a no-brainer which option people will take.
With all the other side benefits, not that I'm promoting a drug, but like you said, there's other benefits that people are noticing with the GLP-1s.
Yeah,
it's
which
not
you
just
won't,
fat loss.
Correct, and which you will not get with liposuction.
Yeah.
You know, it's a visceral fat. It's a visceral fat that's going to be causing cardiovascular disease and reducing your life expectancy.
Liposuction seemed like it was almost being used inappropriately, because I don't think it was ever really designed to be used as a weight loss procedure. It was designed to address a problematic area where perhaps you had
A bulge.
a bulge, or you had a proliferation of fat cells depending on your genetics or your age.
Yeah.
And that's what it was designed for. But now, I mean, it was used just for, an easy way to lose a lot of fat. So maybe it's going to be used for how it was originally intended, which is to remove problematic areas. Because I don't know if GLP-1s you can target weight loss from a specific area.
True. That's a good question. So just to go back on the history of liposuction, I mean, it goes probably back 100 years, but the explosion and the time period where it became fashionable was late 70s, early 80s. A dermatologist famously came up with the concept of cosmetic liposuction. And it was designed mainly for women who had a lipodystrophy, where the upper body was a certain size and the lower body was a much, much bigger size, like 2-3 size differences. And that's how liposuction in the world came about in the States. And just on a side note, if you look at people in the 70s, people were a lot thinner. So liposuction was purely used for that purpose that you just said. It was for someone who had a disproportionate body dimension, couldn't lose the weight. They were going to the gym, had probably good diets and so on. As the 90s came about and the current century and people's diet just exploded and obesity became an epidemic, as opposed to what it was in the 70s and 60s, where people, if you look at photos, everyone was skinny and healthy because our diet changed and, saturated food and so on. And then liposuction came as a bariatric surgery was invented as a result. And then liposuction became the dirty cousin. So look, let's not just waste time and take a tiny bit of fat, 500 mils. Why don't we just go for about 8 liters, 9 liters, 12 liters? And that's how the liposuction clinics did so well financially, but they did a lot of damage. And then you had the mortality and morbidity associated with large volume liposuction in this country and in America. And anyway, that it's come to an end, which is another good benefit of this medication, I would say.
Do you think there's a risk that kind of skill set of someone being an expert in lipo is going to be at risk of kind of being lost? Like, we still need these techniques, right?
Yeah, you're right. They're actually spot on. I think most plastic surgeons, at least, never loved liposuction, and now that is actually not even commercially viable and obviously risk associated. I think it could become a dying breed, whereas because it's a very highly skillful operation, it's very easy to do it badly, but it's very hard to do it well. So I guess at some point the skill might be lost, but I think the savvy young plastic surgeons that I train and we train, I keep emphasizing the importance of it because it's part of sculpting the body in a 3 dimension.
Yeah.
If you want to sculpt someone on the operating table without turning them, they just become blocks. And you're pulling the skin and they just become rectangular blocks. If you really want to give curvature into the body, you've got to use liposuction. So it's an amazing tool when it's used appropriately, and it's a very, very dangerous tool when it's not used. And obviously talking about visceral damage and so on and so forth and problems associated with it. But yes, it could be a dying skill set.
Yeah. Going back to breast trends, you mentioned ballerina
boobs
or whatever. I mean, what it kind of implies a petite look, but what does it mean? Why is it called that?
So basically, my patients have coined the term, they've taught me. So it means that you have a breast enough to have a silhouette, but nothing more than that, just a silhouette, and a silhouette that is not achieved with a push-up bra, because most girls, especially in climates like Sydney and places like California, they don't want to walk around with bras. So have that sort of, let's say, the B cup, perky B cup with some cleavage, nothing too big, but has to be achieved using implant or fat graft, because if you're an A cup, you got to have volume in order to create that ballerina look. So
what led to that trend from big boobs 10 years ago to now this quite sort of petite athletic look?
I think it's a celebrity culture. A lot of what we do is not contrary to popular belief. It's not plastic surgeons. We don't set trends. We just adapt to trend. I think the Hollywood culture of Kendall Jenner, I think she's like the pin-up girl for the small breast, but elegant, beautiful body. And the breast is no longer the emphasis. The Pamela Anderson era of 80s being the extreme. And then she'd be then more of the modern avant-garde version of what a beautiful breast is. And it's cyclical. We all know that. Been long enough now to see at least 2 cycles. And I'm probably on my last leg in terms of the last cycle.
Yeah. Well, last time we had you on, you were talking about potential retirement, and you're still here. So I don't believe that for now.
I think it's one of those things you talk about it, but it just never happens, because the closer you get to it, you think, maybe I'll just push it a little bit longer.
Every time you try to get out, they pull you back in.
It's like The Godfather, Al Pacino.
Can we just touch on the breast implant illness? Because I find it fascinating, because it's so analogous to the fear analogy of, the odd patient you find is they just don't tolerate products or they get rare problems seemingly often. What's your sort of guess or theory as to what's going on?
So breast implant illness is an ill-defined cluster of symptoms which aren't sort of backed up by any biological or a physiological marker. If it was, then it'd have a different name. It would be called lupus or autoimmune disease or Hashimoto's and so on. So when there is nothing wrong with your blood work, yet you're losing hair and you're missing your periods and you can't get out of bed, that was called in the 80s, the yuppie syndrome. You couldn't get out of bed, and chronic fatigue. So if you marry chronic fatigue with someone who's got breast implant, then you have this cluster of issues, and you see various doctors. By the time you've seen your fifth specialist, or the fifth would probably be a naturopath, because they seem to be the best diagnostic people for breast implant illness, ironically. And then, look, it's a process of elimination, Jake. If you've gone through a whole myriad of things, your lifestyle is affected, you have implants, you're naturally going to blame the implant, and quite rightly, the implant's got to come out. But we do have data that 80% of those people don't get better, and that's cold fact. So there's other overriding factors, and there's a ton of research being done, the psychosomatic element to breast implant illness, and so on and so forth. To summarize it for you, I've got a very practical way of talking to my patients, because it will come up at least once or twice during my consult days, and I'll say to them, look, I can sit here and talk to you for 5 hours on breast implant illness, or I can give you a summary. The day comes that you've seen a number of doctors, specialists, and you and your family or your husband feel your health is being affected. You just got to be prepared to take your implant out. And that is breast implant illness. And I can say anything different to that, but once your health is affected and you have a foreign body, you have to look after your body first. And then they'll say, oh, really? So then I'll have a scar. And then I'll say, you have a scar to show for it. Just remember that, so on and so forth. But I have to say, since the COVID, which was the peak of breast implant illness, but both clinical presentation and also media interest, it really has dropped. But going on the topic of chat, our buddy Chat brings it up all the time. Right. So when you chat GTB, the breast implant, it will tell you right at the end, make sure you speak to your surgeon about, which is kind of cute. I think it's fine. Saying, do speak to them about this thing called breast implant illness and these other side effects, capsular contracture and so on. So the good thing about Chat is it does the job for you, but most people who still go ahead. I can't recall the last person who called the office and said, listen, I've just decided to cancel my surgery because I don't want to have to go through a breast implant removal for breast implant illness.
And do we have any data on how prevalent it is? Like how many people are actually out there presenting with, indications that would potentially mean that there's...
Depends which blogs they subscribe to and which Facebook page they go to. And I don't want to diminish it. But it is a little bit related to where you get your information. The analogy would be the COVID vaccine, and the forums you enter will determine the percentage of your breast implant illness prevalence, because there is a psychosomatic element to it. But honestly, I don't believe there's hard data to know what percentage of patients, but it would be my guess in the vicinity of probably less than 0.5%. So very, very small.
Because I know there was a couple of colleagues of yours that were like heavily pushing this as a major issue and had set up businesses particularly catering for removal of breast implants for patients that have, this issue. I mean, do we think some of this has been inflicted upon ourselves by people within the space? I
think whenever there is a negativity in a space, there are opportunistic people who can use that information in a negative, opportunistic way. Don't want to use the word exploitation, but that's kind of what it is. But I've got a very practical approach to it. I'll say a plastic surgeon can or can't diagnose you because there's a massive conflict of interest. You need to go to immunologist. And I think I've got this system really nicely now. It's like, I give you 3 names of immunologists, you make your appointment, I'll do the letters, let them decide if you got breast implant illness, not your GP. And you can consult your GP, but not your naturopath and not your blogs and not your best friend who knows everything about breast implant illness, except she doesn't have breast implants herself. So that tends to work for the patients, and they go and do independent research and generally come back and say, doctor, thank you so much, and yes, I've decided to go ahead and have my implants removed, or no, you're right, there was something else was going on with my health at the time and it's been rectified, and thanks for guiding me.
You and I were talking about this the other day with there's a lot of Facebook forums, or at least there's some well-known ones, where people are adamant that, injectables, particularly toxins of any brand, have created a similar issue, sort of chronic fatigue-like symptoms or other unusual symptoms. And I can't find any evidence that is definitive that it's true. Otherwise, obviously, that would have a massive implication on my job and my patients. So it's similar where you go to a Facebook forum, you get a lot of confirmation bias that there's a real problem, there's a link, and you sort of, you're in an echo chamber of patients, understandably going through their own life experience where they're saying something's happened. But it's hard for us doctors to reconcile because we don't see it in our everyday practice. You've treated thousands of patients, I've treated thousands of patients, and I've not met one patient who that's happened to yet. But that's not me saying it's not true. The science isn't there to sort of back it.
Yeah, I think you're absolutely right, Jake. I think the science isn't there, but I think the approach for facial surgery would be very similar. You've got dissolving agents and we have removal. So we'll just say, look, if you feel your filler is giving you X and Y and hair loss and fatigue, why don't we just dissolve you and then just stay away from it? Yeah. And I think that's our job, that there's going to be a certain percentage of our patients, regardless of where they get the information from, who the surgery that we do for them, especially if it involves a foreign body, doesn't agree with them. Yeah. And can we define it in 2025 scientifically? No, because we just don't have the sensitivity of our tests to pick up a reliable indicator of breast implant illness or a granuloma type situation of the face. Maybe it will come about in a few years' time. Yeah. But we just got to be in a position to be able to reverse it and say, okay, all right, well, I don't know if you've got it, but implants are coming out. Let's just fix you up so you can get on with your life.
Yeah. Breast lifts, breast reductions. What are the indications for needing that surgery these days? And have there been any advancements that make the procedure less of an issue from a scarring perspective?
Yeah, I think that's a good question. I think scarring, even in the time I've been a plastic surgeon and 5 years prior to that as a registrar, I think just knowing how to open up a breast and keep the skin viable and avoid necrosis, avoid infection, avoid inflammation, better suture material, better suture technique has improved scarring to a level that we show them average of 10 patients will say, well, look, most of them look fantastic, and their expectation, most patients' expectation of scarring is really bad. And I'm not sure if it's something from looking at the mums having had surgery or looking at an abdominal surgery done by a general surgeon or so on and so forth. People think they're going to get these massive scars. Has always been the reluctance, especially with breast lift, where there's not a functional surgery like a breast reduction where you're getting so much side benefit from it that most people who have like chronic pain in the neck and so on and they can't exercise, they'll just used to say, oh, look, I don't really care. Don't even show me scars because I don't really care. I'll just do the surgery. But the breast lift patient is very, very sophisticated. The patient, is usually a young mom, early 30s with 2 kids, and she wants the best outcome. She wants a Rolls Royce scarring. And that's where it's been a huge amount of research. And I think our work is a lot more refined compared to even 10 years ago.
Going back to the topic of liposuction, you're now doing lipofilling for the breast. So is that going to cater for creating a better shape, but also removing the need for implants and making patients feel a bit more natural about the whole process?
I think lipofilling at the moment is not as effective when someone is a complete A cup and flat chested, because it's just the graft take is not predictable. To reliably take someone to surgery, charge them X amount of dollars, do the liposuction, put the fat, and just doesn't take. It does work well in a technique that I've created where the breast lift, I utilize a lot of fat during the breast lift because it lends itself nicely, because breast lift patients, generally speaking, as a whole, can't tolerate implants anyway, because the implant eventually will drop. Especially with the GLP agonists, this has been accelerated because of that phenomenon we spoke about, the rapid loss of elastin, collagen. So if you then see a patient and she goes, I want an implant and a lift at the same time, you are more likely to be facing complications and revisions and so on. And hence the piggyback of fat and the lipofilling, it just seems to be a perfect marriage, perfect blend to alleviate the need of an implant. And also, obviously, the breast implant illness and so on. So if you can avoid using implants in the first instance for a myriad of reasons, I think patients generally are quite welcoming.
So can I ask, how do you do the lipofilling? You obviously take traditional liposuction fat from somewhere, and then how do you process that fat?
So we just wash the fat, prepare the fat, and remove the blood. And sometimes I spin the fat to get the oil out, because the oil causes all the cysts and so on, and necrosis and so on. And then just in a traditional way, like you guys inject the face, we inject the breast with cannulas, avoiding major vessels, obviously, to avoid embolus and so on.
So it's not nano fat?
I use nano fat, Jake, but it's on a different level. Nano fat is on a much more superficial level. Right. So if you look at like a laminar structure of the breast or face, there's no point putting nano fat deep.
Okay.
So you put the micro fat deep, and then as you build towards the skin surface, the particles of the fat can go into nano and create different effect. The nano fat does not give you any volume. It's just a shape change.
Okay, so exactly like filler, bigger globules for deep and structure and refinement at the top.
Identical.
Okay.
And you're using fat as a hybrid technique with implants as well.
I do that as well,
to sort of hide or mask sort of demarcation lines. Is that something sort of commonly doing? Is it a similar technique?
Yeah, that's something I came up with, and I was quite proud of that about 2012, 2013, where got a lot of resistance by especially the insurance companies. It was a completely dirty word, fat grafting. And then we had a lot of meetings with the medical insurers, and they came on board and said, like, cancer patients are having fat grafting. Why can't we have it? And sort of we worked with them, and now it's become commonplace worldwide. So Australia has been a major hub of research in breast surgery, both in terms of, less so in terms of actual implant technology, because we just don't have the resources of big companies. I have a breast implant company in Australia for that purposes. We do rely on the Americans mainly and some Europeans, but in terms of technique and especially anatomy, we've been at the forefront of changing things.
What about internal bras? We mentioned bra and people not wanting to wear bras, they want to feel as natural and aesthetic as possible, but there's the internal mesh system. When would that be appropriate? Why do you use it, and what are the complications, I guess, with that as well?
So the internal bra has got different meanings to different surgeons, and it's can be used more of a marketing term, but in the actual scientific forum, the internal bra is where really you're using a mesh. And if you're using suture material and calling internal bra, it's just a bit of a misguiding your patients. So yes, mesh has become a big part of our practice in breast surgery and abdominal surgery to some extent, but mainly the mainstay is the breast. Again, we've borrowed the technology and the understanding and knowledge from breast reconstructive cancer patients, because they need it because of the amount of tissue gets removed. And when we spoke to David about the podcast, mentioned the GLP agonists, and how because of the GLP agonists, again, we come back in circles, and patients wanting larger implants, but because of the rapid loss of tissue, the bottom of the breast is not strong enough to hold a bigger implant. And I'm not talking massive, I'm talking even 400, 500 cc implant, not talking 900. And we're talking like mid-range, that they can't hold the implant and they need volume, and that's where mesh, the market has exploding in Australia. We are a little bit slower in terms of our TGA to approve them, because there's a bit of bad blood with mesh, not in breast surgery, but in gynae surgery in Australia, as you know, and worldwide. Americans have been actually quite good in taking up the meshes, FDA. So we would just usually wait for the FDA to approve the product and then bring it here and use it. So I use quite a bit of mesh, and we've about to get our largest probably Cosmetic series published in the world, 50 patients in the PRS journal on cosmetic use of mesh in breast surgery.
I was doing breast surgery 10 years ago in the UK, and we used something called Stratus. It's like a porcine.
Yes.
Was it a dermal matrix? That's what they call it?
That's exactly right. It's a cellular matrix cadaver skins, which was either human cadaver or porcine. They were quite in vogue. They became less so. A number of reasons. Cost was a huge component, even though cadaver rib graft has basically replaced rib graft in rhinoplasty, for instance. But and the cost is a lot less. But in terms of actual using it for breast surgery, the cost is still quite astronomical.
Right.
15 to 25,000 a sheet.
Oh wow.
Whereas a mesh is like 4,000 or 5,000. So the cost was a huge part of it.
Yeah.
And then there was that porcine element, which was, some people just didn't know what for cultural or religious reasons have that, and so on and so forth. And there has been a big shift away, Jake, from that kind of material to synthetic.
Things have moved on.
Synthetic.
Right. So your mesh, what's it made from?
It's a combination of polydactyl material, which is like what PDS is, and
like suture material.
Suture. It's basically suture material.
Okay.
It's just on a grand scale.
Yeah.
That's what we tell patients.
And so when patients hear this concept of internal bra, which sounds really cool, what does it actually look like, and how do you stitch it in?
Yeah, so it basically engulfs like a basket. Just imagine an implant goes on, and I normally tell the patient it's like a light fitting, like a chandelier.
Okay.
I suspend it from top of the muscle, so the base of it almost has no pressure.
Yeah.
And that's what the most complications happen in breast surgery. In breast implant surgery, if the base of the breast is unstable, you get movement. Once you get micro movement, then you get macro movement, and then you get displacement, and then you get things falling out. And
okay, so it's like a hammer across sling to hold the implant in place. Correct, basically.
Yeah.
Cool.
Interesting. And in terms of things that can go wrong when using mesh, is there sort of any complications that people need to be aware of once you integrating that type of technology into your procedure?
I think anything foreign, you got to be aware of infection, and we've been very, very lucky that we haven't had any in my series. But that's the number one thing you have to. But I think a lot of it is technique related. You've been a surgeon and you have like sound technique, and don't create necrosis that we spoke about before in tissue. And necrosis is the commonest cause of infection. If there's no blood supply, then things get infected. Just using securing it properly, because I always tell my fellows and registrars there's two breasts, so make sure if you do one properly, make sure the second one is secured the same way. So because it's a mesh, there's no dropping. So they have to be secured perfectly at the time of the operation. Those are the things, just learning curve, costs, and so on. More theatre time, more operating time.
That might sound like a silly point to our listeners, but I remember we used to operate on each side of the bed. You'd have one surgeon doing mastectomy, the other one doing something else, and it's got to be the same.
I think that NHS style is becoming less popular, and especially in the private sector, I think you need both surgeons be the same person. I don't think we can afford, in the era of social media, to have different surgeons doing different things and patients waking up wonky, because we've moved away from those times.
Yeah, we were talking over a colo about that particular problem of maybe new techniques being used. We were using an endoscopic facelift as an example of, it's good to push the boundaries, and it's good to, even for yourself, to kind of be at the cutting edge of surgery. But where does the boundary lie between, being at the cutting edge of innovation and in fact risking your patient? So when you was doing things like mesh and everyone was pushing back,
fat grafting, yes.
What made you sort of have the confidence to do that?
Yeah, look, it's a very interesting area of surgery. Step back in your trajectory of your education and then your training, and think to yourself, where is your comfort level? It comes down to your comfort level, and comes down to how subjectively you look at your work, and you think to yourself, the question really is very simple. Could I do better? Could this result be improved? Could her outcome be better? Not just for safety, obviously, that's paramount, but also aesthetically. And I think if you ask that question of yourself on a continuous basis, and your brain is engineered in a way that you would want to be innovative as opposed to be comfort. A comfort surgeon, it does the same thing that they did 20 years ago, and it's a job, it's no longer a craft. And if you think of yourself as a surgeon, as a practitioner, a health provider, but also as a craftsperson, you kind of will want to improve it. Same thing as a guy who's sort of building a beautiful boat. The second, the third, the fourth boat has to be better than the first boat. Yeah. So because there's an element to our work which is aesthetic and artistic and not really defined by science.
Yeah. If I could add to that, because you're experienced, you kind of know your boundaries.
Yes.
You know what seems too far, and you understand what's going to augment what you're already doing. And I think without that experience, it's hard to know.
Yeah, it's
so for a new plastic surgeon, it'll be harder.
I give the analogy to my patients and even to my kids sometimes. It's like motor racing, Formula One. You know, you keep racing and taking those chicanes, but every now and then you're going to spin. As long as you're not spinning all the time, you can still become world champion and you can do well. But what we do is a bit like motor racing. We're pushing the boundaries to get the best outcome for our patients. Otherwise, if you want to just start the race and finish the race in the last position, then that's one way of looking at it. But we have to be aware of not being too experimental and doing silly things. And also, I think to add to that, Jake, we are living in a very highly regulated country where you couldn't get away with that kind of stuff anyway. You know, we're not. I'm not going to name countries that you could get away with that, but Australia is not one of them. If you were one of those Dr. Frankenstein type personalities, you're in the wrong country to be, you know, providing your craft, because you're scrutinized to the nth degree for the right reasons.
Yeah,
and you wouldn't be doing anything silly.
Yeah. Well, speaking of scrutiny, we're living in a pretty heightened regulatory world these days. You know, you were a bit of a trendsetter when you were using sort of, you know, Snapchat sort of do live surgeries and showing people what was going on. Obviously, there was a little bit of pushback with that. Like, what's your current view today? Sort of, you know, live surgeries, you know, educating people. Like, where do we draw the line? And, you know, what's your overall thoughts on this?
Yes, I was a lot more risque in my 40s with that kind of stuff. MySpace was the first one.
Yeah.
MySpace, Facebook.
Really?
Showing
MySpace?
my age. Yeah.
Wow.
Instagram, then Snapchat when it all exploded, and we had an international presence with Snapchat. And then, look, I think when the writing was on the wall and the letters kept coming back from medical board and our society that they don't like the concept of cameras in theaters, you know, I respected that, accepted. It was good. Like, it, you know, taught people a lot of things. And it's still being done overseas. So patients, the good thing is patients can log on to a Colombian surgeon and a guy in Miami and watch the surgery. So they just can't watch you anymore because our regulatory body is like, you know, if you like, our big brother doesn't allow it. So we have to be respectful of the house rules. Our house rules are different to a surgeon in London. Even ironically, I'll say that because you're English. I used to go to London all the time and see my colleagues and friends and say, oh my God, I can't believe you were doing this stuff. We were watching you 2 days ago. And this is like 2016, 2017, 2018. And now when I see them, it's like, something happened to your social media. And obviously they know about what's happened to Australia. It's all been shut down. But we were at the forefront of setting trends together with Americans in terms of our global presence in social media for a tiny country. But as you know, APRA and medical took a different view to all this, and partly because of all the issues with the Cosmetic Institute and, you know, the liposuction clinics and, you know, all the complications came out. But whether they were related or unrelated, it didn't really matter. Once the hammer comes down, everybody gets treated the same way. And a major overhaul happened in social media in Australia, and now it's very vanilla, very bland, just before and after photos, and don't say this and don't say that, which is fine. It's just a different set of rules.
To touch on what you just said, do you think that Australian regulators are a little bit, not naive, but they can't ring fence things because they just jump on another Instagram feed and watch whatever they like? What's the purpose of trying to control that when it can't be controlled?
Good. That's we've had many conversations with ARP and medical board, and basically the best way I can tell you is it's like parents disciplining their own children as opposed to disciplining your children. So they don't care what your kids do. They don't care what the Turkish plastic surgeon does and the guy in Colombia or in Brazil does. It's not their concern. They understand on social media they have accessibility. So we're not here to tell the Brazilians what to do or the Americans, but we're here to tell you what you can do within the boundaries of Australia to Australian patients who are going to be looking at your social media and get influenced by the content you produce. Yeah. So we can control that, but we don't really care what happens outside. And then our argument was, just briefly, if they look at the overseas ones, they might get enticed and just get on a plane and have surgery that will put them in harm's way, and their reply was, we don't care. And that wasn't an arrogant reply. It was like, we don't care because there's nothing we can do about it. It's an international matter. Someone decides to go to, say, Turkey, which is the biggest hub. I mentioned that because it is our biggest hub of overseas plastic surgery. It's definitely overtaken Thailand.
Really? Even for Australians?
For Australians. Oh, of course, the whole planet, I would say. They'll say, well, that's, it's an adult, makes a decision, gets on the plane, and when they come here and they overburden the public sector, we just have to accept it because our Medicare system allows it, that if you come with an infected implant or something, then the hospital has to look after you. So there's no rule to say that because you've had surgery in Turkey, we're not going to treat you, because we don't have that system.
So you may not want to answer this question, but what do you think the overall net gain? Do you think that the risk of people being unduly influenced by watching what you may put up on social media outweighs the risk of them, or the benefits of them actually getting educated and sort of seeing what a surgeon can do here in Australia, staying here in Australia, versus, the opposing viewpoint?
I think the rules have changed. I think the rules of, look at me, I'm better than the other guy, my results are better, has changed. You have to use a different strategy now to, if you're starting let's just talk about a young plastic surgeon starting out. Don't worry about me, because hopefully after 20 years, I've got enough following and word of mouth to fuel me for the next 5 or many years I've got left. But if you're a young plastic surgeon, you're gonna have to go back to square one and think, okay, things have changed. I'll have to take an educational approach to social media, and that's what the boards and APRA want, that you educate the whole time and you don't glamorize plastic surgery, you don't trivialize plastic surgery, you emphasize complications, you emphasize recovery, you put a lot of onus on expectation. Those are the things that medical board wants, which, the correct things to do. Is just on a global scale, we are just now not even looking at any meaningful marketing. I mean, what we do here is not defined honestly as marketing worldwide. So you would almost go and say marketing in plastic surgery in Australia is almost dead, which means that it's gone back to the traditional way of word of mouth and all that kind of avenues of generating patients.
So to summarize for our overseas listeners, what changed? What can't you do now that you were doing, 5 years ago?
Everything, just before and after photos, the top of glamour shots, bikini shots, operative footage, talking during surgery, testimonials, people saying stuff about you, comment section being turned on, and then someone's inadvertently, God forbid, say you're a good surgeon, and then you get penalized for all that. And then there's a point system that if you keep getting penalized, you can get your digital media banned. So the stakes are too high to be doing that kind of stuff. Before and after photos, having the same lighting, they can't put makeup on a facelift afterwards, and it's just a fair game.
Yeah.
But for an overseas listener listening,
very punitive compared to what they're doing.
They would just laugh and say, well, we do all that and probably more, because once you enter that market where you have no rules, it's like Mad Max.
Yeah.
You do everything. It's like craziness.
Yeah.
And that's what's been taken back to, okay, let's be civilized. Let's be civilized with our marketing of plastic surgery, and let's not allow the vulnerable patients that we do have a big cross-section of them in our specialty to be enticed by marketing ploys. And
Did you have any regrets about how you used to do things, market, Snapchat?
No, don't have many regrets. I think I just play the rules that was given at the time. I didn't bend the rules, but I didn't break any rules. Yeah. I think we were at the forefront of it. We did things, it was analyzed, it was frowned upon by some, but you know what, if people don't criticize you not doing well, we live in a country famous for tall puppy syndrome, people get taken down all the time.
Yeah.
If you're not pushing boundaries, if you're not irritating people a little bit, then obviously you're not doing a good job of growing. Yeah. But with the same token, and we know a lot of people who overstep the boundaries and do unscrupulous things, the concept of collegiality goes out of the window. And I think those are the things that especially a young surgeon has to avoid, because it's a 30-year career. I keep telling them every time I'm teaching them, it's not a 3-year career. It's not like the hospital system. You spend 1 or 2 years, you can piss a few people off. Once you enter the specialty, people will know you for the next 30 years, and what you do now, people will remember. Yeah.
Do you think it's the career trajectory for a newly graduated surgeon, whereas they used to be able to just open up their own practice and market and have patients, but is it, you said it's going back to old school. Are they now having to go and work within someone else's practice, start off as used to see plastic surgeons that would come and work within someone else, like a senior consultant's practice, and they'd eventually take over because they just couldn't market themselves. They were that was how they got started. Do you think it's going back that way?
I think it's a combination. I think a lot of it is a combination of personalities. I think personality of a surgeon will govern a lot of, to a large extent, how they're going to build this practice and the speed of how they're going to build this practice. But the traditional way of, the traditional would have to go back to the 70s and 80s. That was purely driven by a general practitioner in an environment that were like 7 plastic surgeons, so there was just no effort. You could do anything and you still be having an extremely busy practice. In terms of the younger guys coming now, there's a lot of competition because they opened training up about 10 years ago and the numbers exploded. And I remind them all the time, their retirement age is no longer 60, because a 60-year-old plastic surgeon now looks 40 and he's healthy and runs around Vaucluse 5 times a day and is keeping up, and that coupled with the number of newer guys coming through means the market is saturated, which is what I think the College of Surgeons and Health Department, they wanted more competition, and they've achieved that. And more competition means that people become better at what they do, prices come down. And that's their response to overseas surgery. If we bring our prices down here, what would people get on a plane and go to Thailand and Turkey? You guys are too expensive. But that's a very complex thing. We have this thing called a tax system here, where they don't have that. We have something called the wage system here, where people are getting paid, high wages, but they don't have a wage system, and that's why the prices are so much lower. There's no aftercare when you have surgery overseas. There's aftercare here. So a young plastic surgeon here will have, I would say, a much tougher time. And also, they will stay in the public system more and help with the reconstruction and trauma, whereas, maybe the generation of my generation spent maybe 1 or 2 years and got out. Now they have to spend a little bit more time doing reconstructive plastic surgery.
Do you think that may have been one of the motivating factors, is to keep doctors in the public system?
I don't know if it's a direct result of it, but I think the direct result was to push people to the countryside, to regional Australia, and it hasn't worked. I'll be very honest with you, because they still want to be in Double Bay and Rose Bay and Bondi Junction, and you don't see 10 plastic surgeons in Dobbo and other places. Has gone a little bit more into, say, bigger centres like Newcastle. I want to talk about New South Wales because I know it, and Wollongong. Compared to when I was training, there was 1 plastic surgeon per city. There's like 10, but the smaller places still hasn't gone. And I think it's the personality of someone who becomes a plastic surgeon probably is not likely to go into the super regional places and set up. So I guess that was the main aim. But indirectly, being more plastic surgeons, people travel and maybe spend a day, a month in those places and come back, as opposed to go and set up a whole practice in those places. So it has had some benefit by training more surgeons.
I guess final question or two. So we've got this weird dynamic where patients are getting all their information on social media. They're glued to it. It's the first place they go to. I think you said that earlier. And you can't showcase or do what you want to do. So what does the future look for surgeons or even injectors? Like, how are we going to educate patients when our hands are tied behind our back?
So education, I guess, in terms of pure conveying information is what they want us to do. Before and afters are legit, but they just got to be of certain quality. And, just the anti-American system of don't ever say anything good about yourself. Let other people say good things about you, because Americans, all they do is talk about it. So I apologize to all the American listeners.
I was in the States in February, and having lived through 2 years of strong regulation here, where, we're all on the fence about what was good, what was bad. Sure. it shocked me how different it is. And I was like, no, I prefer the Australian way. So
yeah, when we go there, it's almost like, oh, what, this is too much. I can't go back to it. And Dave was, you have regrets. I was like, you know, it was fun. It's like anything you do in life is fun. It's like a school this week. It was fun. It was fun doing all the Snapchat and stuff. But no, I don't want to go back and doing that. It's actually a lot of work. Social media, the way I was doing it, those 3-4 years that I was heavily into it, and I had 2 girls working on it. It was actually a lot of work. It was like you finish operating and then you had to do 2 hours of editing, and like now it's like life is easy. I think I have to thank Alfred for giving me all this extra time, free time to do other things outside surgery.
Yeah, fair enough.
Yeah.
Any final questions from you, Ben?
No, I think we're all good. I think we've grilled you enough. Jake's asked a few Piers Morgan style questions there about regrets and put you on the hot seat.
I was hoping for a more emotional answer, but I didn't get it.
I don't mind Piers Morgan. He's an avid Arsenal fan, so even though people don't like him, I always stick up for him.
We're on a plane tonight to go and watch Arsenal.
Yeah, so I'm leaving in a few hours to go to London. I'm taking my son to his first Emirates game, so
nice.
Very jealous.
Up the Gunners, so hopefully we get a good outcome, and he'll be walking out of the stadium not crying.
Yeah,
in a good way.
Absolutely. Well, thanks for your time, Kourosh. It's always good to see you. Thank you so much for making the time.
Hopefully we don't have to wait 5 years to catch up again.
We'll get you back earlier. Thank you so much.
Thank you very much,
Appreciate
Jake.
it.
Thanks, buddy.
David.
Speak to you soon. Thanks, brother.
Take care.
Bye.
We hope you enjoyed that episode, guys. To stay up to date with our latest news and episodes, follow us on Instagram, and we're now on TikTok.
You can also now watch our full video episodes on YouTube and Spotify. So if you like what we do, please give us a like and subscribe. Please also consider joining our Patreon for invaluable business and injectable education. Get access to our global community of like-minded professionals, hints and tips videos, bonus podcast content, and more.
All of our social links, Patreon, and contact information are in the show notes below, and we'll see you in the next episode.